Welcome to this Peer Voice activity. To access the entire activity, including supporting material, go to www.peervoice.com/acq. This activity is supported by an educational grant from Sanofi.
Welcome everybody. I think we're going to make a start on this session on innovation through immunomodulation. We've got 90 minutes together when we're going to take you through several steps to inform you a bit more about this area. Here's my panel. We have Mike Haller from the University of Florida in pediatrics. We have Olga Cordonori from Hanover, also in pediatrics, and I'm also a diabetologist, but an adult diabetologist. So I'm the odd one out in this collection. But I think we've all been thinking about these topics for a very long time, and hopefully we can share our expertise with you. We're going to start off with the case for change. Why is there an issue? We've got fantastic tech now for type 1 diabetes. Do we need to do something different? So we'll discuss that a little bit. And that'll lead us to thinking about immunomodulation. So we'll go to a bit of the theory on immunomodulation, immunomodulatory interventions in T1D, and that's thinking about the background and how we make that into a reality for our patients. And then we'll be talking a bit more about the implementation of immunomodulation, sharing insights with what we have experienced around using infusions of immune modulatory drugs to treat our patients. And then finally, there's a big step, because it's a big change not only for you, but for our patients and other healthcare professionals. We want to talk a little bit about prioritizing the patient experience and what it's like to actually make a change in your practice with these kind of drugs as they become to be introduced. And then we will have time to have a discussion. Okay, so now I'm just going to say a little bit about why do we need to do something different in this particular area. So I think we need to start from the fact that type 1 diabetes is not a metabolic disease. We always treat it as a metabolic disease. And it seems to come as a surprise to a lot of people when you say, but actually it's an autoimmune disease like rheumatoid arthritis or psoriatic disease or inflammatory bowel disease. And you go, oh, is that right? Do you treat those with insulin? No, you don't treat those with insulin. We treat them with the treatment for disease modifying to treat the autoimmunity. And I often say that it's because insulin is a blessing and a curse. Sure, it's a blessing, and when it was discovered, it stopped people dying from this disease. But it's turned it into a chronic disease that we have to manage for a very long period of time. And so that becomes a curse for us in one sense, because all those other conditions have new drugs. They have MABs, they have other things that have been with them for 20 years. We haven't had it because they say, oh, well, you have insulin. Why would you need another treatment? And just thinking about that a little bit further, we have... As I was coming up the path today to the meeting, I saw Tandem, a big Tandem sign. And I thought, this is the first time I've seen type 1 diabetes dominating here the conversation. It's dominating above type 2 diabetes because we've got such great technology. And that's really exciting for us, and it's moving us all along. But insulin is still the most difficult drug we ever ask people to handle. And not everybody can handle it. Even then, you've got to fill your pumps, you've got to have all the kit with you all. When you travel, it's a big amount of kit that you're going to have with you as well. So although it's definitely improving outcomes, the outcomes are not the same as if you didn't have diabetes, and it's still a big burden. It's still a big effort every day to think about what's going on, and it's there because you have all this paraphernalia attached to you to deliver the insulin. And there are people, as you know, who find it difficult to adhere to this, particularly in the teenage years, but also other people with mental health issues, where this whole thing is just a little bit more tricky to deal with. And unfortunately, it's for those people where the outcomes are not going to be as good as we would like them to be. So being able to take away that burden would be something very special. And if you haven't thought about it before, I want you to just think about, what if there was no insulin? What if you didn't need insulin? What if your beta cells were good enough that you didn't need insulin? What does that mean? Does that mean no jabs? Of course it means no jabs, but it means a lot more than that. And a lot of people don't quite think that if you don't need insulin, you won't have hypoglycemia. The treatment for diabetes causes hypoglycemia, not the disease itself. So as soon as you don't need insulin, there is no hypoglycemic risk, pretty much. Well, if there's no hypoglycemic risk, you don't need to monitor. Nothing's going to happen. Nothing's going to catch you out. Imagine what that means when you spend your whole life thinking, what is happening next? There's my sugar is going down, what's going to happen? No, it is not going to happen. So you don't even need to think about it. And if it's not going to happen, it also means you can eat what you like. You can do every exercise you like. This is not going to cause you a problem. So if you're a child, you can do what you like in terms of sport at school. You can have the same lunches that everybody else. You don't have to be separate from it. And you can manage all of those things. Just beginning to picture what that does in terms of transforming the stresses in your life. You're not sitting on the edge of a precipice. A colleague of mine said that having type 1 diabetes was like you're on a plane and someone says, sorry, I need you to fly this plane, please. And they make you fly the plane when you've never been a pilot before, and the plane never lands, right? You have to fly this plane and learn how to do it straight away, and it never lands. So you always have that anxiety that something's going to go wrong, even 20 years later, 30 years later. And that goes if you don't need insulin. But there's more to it than that. If you don't need insulin, you don't have diabetes. Well, what do I mean by that? I mean, you may well have the autoimmune process, but your sugar levels, your glucose levels, are not in the diabetic range. And the diabetic range is defined by the range at which you're at risk for microvascular complications. So if you're not even in that range, you are not at risk. For as long as the time that you don't need insulin, and of course you have good control, you are not acquiring any risk. You are not at risk. So we often say, I mean, now with some of the technology, people are getting HbA1cs in the 7% range as an average, which is just amazing, sometimes a bit lower. But that means quite a lot of people have HbA1cs above 7%. And above 7% means you're still at risk for microvascular complications. And in particular, you're at risk for cardiovascular disease, because the risk of cardiovascular disease is much lower than that. So you haven't got rid of that increased cardiovascular risk, which is going to catch you out later on. But if you don't need insulin, and you don't, in inverted commas, have diabetes, you don't have even that cardiovascular risk. And what if it's only a period of time, it's only a couple of years that you don't have diabetes, let's call it that. Is that worth it? You think, bring it on, let's deal with this. But remember the DCCT trial. That improved control from 9% to 7% for 6.5 years. And it had benefits 30 years later. 30 years later, the risk of cardiovascular disease and retinopathy was about 50% less than it would have been without that. Even though nothing happened after that 6.5 years, the HbA1cs came back together. And that's what people, as you know, refer to as metabolic memory. Well, how about if you had an HbA1c of even better than 7%, you got an HbA1c of 5.8%. How much metabolic memory are you going to get out of that for 2 years? And as I often say to people, you don't want to invest in your pension when you're 65 years old. You want to invest when you're 18 years old. So the benefits the benefits are best early on. So the delay in the intervention, you get much more bangs for your buck in delaying 2 years and not having diabetes for 2 years right at the beginning than you do if you were 55 or 45 or 35 years old. So it's not just a little holiday, it's putting money in the bank. And money that will improve over time in terms of your long-term risk. So that even if you, let me say, screw it up later on, then you've already got this protection. And it's the protection we know about from the pediatric side, where they say, I wish people were diagnosed earlier rather than 2 years. I'd rather they were diagnosed at 5 years or 7 years or 9 years or 10 years or 18 years. So every year that we push it out gives them these additional advantages. And just think a little bit further around this. So I said insulin was the most difficult drug we get to ask people to do. The dose is different every day. Oh, how crazy is that, right? And then you have to match it with your exercise and your food and this and that and the other. Can you imagine any other drug that's that complicated? And we mentioned that there are some people for whom this is too challenging. This is difficult to adhere to. But immune therapies are pretty straightforward. I mean, we're going to hear that some of these are just an infusion. There's no other therapy. There's nothing you can get wrong. You can't get it out of you. It's happened. The benefit will stay with you for those 2 or 3 years. Whatever you do, you can't undo it. And some of the other therapies are given, some monthly, some subcutaneously, but there is no different dose. It is one dose per body surface area, but it's a standard dose. So that means that everybody can benefit. It's not just the people who have a supportive family and have the finance and have the low stress levels. And more importantly, reaching out to those people who find it very difficult is the most important thing to do. So this is a therapy that can reach the people that other therapies can't reach because it's done. They don't have to do anything. They can make it work. And it's those people who have all the costs and the problems with long-term complications. And I often think of it as double jeopardy. We published a little while back the fact that people with a not very good HbA1c have very poor schooling out results. And it's not because the blood sugar's affecting their schooling, it's because if you can't deal with one, you can't deal with the other. So you end up in a low-income situation because you didn't get good schooling, and you've also got diabetes complications. So immune therapies can begin to unlock this. They can begin to separate these effects in the longer term. So this is beginning to bring all these factors together in a way that we can see diabetes from a very different point of view than the way we've seen it before. So finally, of course, you think there is no free lunch. Is that right? There's no free lunch? I thought we had a free lunch out there. No free lunch means benefits versus risk. And when I first started talking about immune therapy to people, I was told, don't do that to our children. We don't want that. That's cyclosporin. Please don't poison us. We'll be hearing a lot more about benefits and risks through the later part of the meeting. But I think people are familiar with that. In all these other diseases, they think the benefits outweigh the risks. And these drugs have got safer and safer. So we'll hear a bit more about it, but I think now the reason this whole story has changed is that the benefit-risk profile has changed. These are selective immunomodulators. They don't ablate the whole of the immune system. They don't result in long-term immunosuppression. It might be transient, but in the long term, there isn't a long-term risk of infections, cancer that we think is going to happen. So I just wanted to put some of those thoughts to you as you're thinking about why you would need to do this and just move on into a new era of insulin-free diabetes. Okay, so I'm going to move on now a little bit, just setting the scene. So let's talk about immunomodulatory interventions in type 1 diabetes. Let's turn that potential that I've just been discussing into actual progress here. So Olga, I'm going to turn over to you to just tell us a little bit more about the background to type 1 diabetes.
Thank you. Thank you very much, Colin, and thank you very much for the nice introduction to the field. My job now is here to show something you may know very well, meanwhile, but most of us, we are very well trained to treat people manifesting type 1 diabetes as stage 3 when they are symptomatic, and you see now, and of course, if we have also learned to look for antibodies, and we know that they have at least one type 1 diabetes associated antibody at that time. But now we know very well that the story begins much more earlier, years before, with the stage 1 and 2. Indicates that we have a multiple autoimmunity as the main criterion for representing the autoimmune process, which happens. And then in the stage 1 and the stage 2, we have the first signs of dysglycemia, and so as you see here on this chart. We know this process for more than 30 years, actually. And this is not surprising to see that meanwhile we have a lot of concepts have been proved in the different stages, and of course we start with stage 3, and you see the agents have been used in major randomized clinical trials in order to modulate the process. Not that all of them, they're not immunosuppressive in the dose and in the kind they are given, but this is immunomodulatory agents, and we use different ways, subcutaneous or oral or IV infusions. Mostly there are, as Colin said, not for the whole period of time, for the part of time. And we have also the TNT stage, the TNT study at stage 2. And we have tried some concepts also in the very early stage 1. And this is the T1D trial, the teplizumab, which was conducted in relatives of patients with type 1 diabetes at very high risk of reaching stage 3. And the primary trial, the primary analysis showed that the median time to diagnose type 1 stage 3 was 24 months longer than in the placebo group. And this is also this is why this trial has proven that this is has a possibility to delay the onset of diabetes stage 3 by 2 years, in an analysis after that up to 3 years. We know quite well how the teplizumab works, and you can see on this slide on your right side showing that the subpopulation of the exhausted CD8 positive cells is raising, and those they're getting the agent after 3 and 6 months after the treatment. And on the other side, you see also the effects of the action, showing that we're expecting to have some kind of lymphopenia, which reaches its nadir at the after day 5 of treatment. They're quite this picture is very important for me, because this is something it help everybody later on during the monitoring of the treatment to understand what you see on the patient. The teplizumab has been used in patients mostly with stage 3 diabetes for more than 20 years, and we have a very good, very distinct information about its safety profile. Here you see the numbers from the T1D trial. You will see the changes in the blood count in every patient. This is something we expect to see. Half or 2/3 of the patients getting the drug may develop a rash, which is with or without itching, very good during the treatment. And we had the risk of cytokine releasing syndrome, but it is less than 2.5%. And this is also maybe to get a long story short, the reason why teplizumab has been approved as the first disease-modifying therapy treatment for stage 2 type 1 diabetes in patients who are older than 8 or 8 years or older. And this approval was given by FDA in November 2022. And in January 2026, that means very recently, was given also by EMA.
I think we're going to hand over to Mike now to tell us about a couple of other treatments. Mike, over to you.
All right, thank you. So we're going to talk now about another disease-modifying therapy, namely thymoglobulin, anti-thymocyte globulin. That's a polyclonal mix of antibodies to thymocytes made by immunizing rabbits with thymus tissue. In TrialNet, we performed a study in stage 3 patients, new onsets, classic new onsets aged 12 to 45 years, and demonstrated that a single course of 2 days of low-dose anti-thymocyte globulin provided highly significant preservation of C-peptide out to 2 years after that 2-day infusion compared to patients who got placebo there. You can also appreciate that low-dose anti-thymocyte globulin is one of the few agents that to date has been able to also demonstrate a significant reduction in A1C after that immunotherapy treatment in new onsets. And this is important because as great as teplizumab is as a first disease-modifying therapy to make it to market, we clearly need more than one tool, and this mechanism is an attractive one that might provide alternatives for other patients in certain situations. TrialNet's not the only ones who've studied low-dose anti-thymocyte globulin. Most recently, the Europeans studied ATG in the minimally effective low-dose or MELD ATG phase 2 study. In this effort, they enrolled participants from 5 to 25 years of age, also recent onset stage 3. And we see here that they studied a few different doses of ATG, trying to find what that minimally effective dose was. It's a very clever adaptive trial design that initially used some immunologic features to rule in or rule out lower doses than the 2.5 milligram per kilogram we used in TrialNet. And what they ultimately ended up with was a 3-arm trial of 2.5 milligram per kilogram, what I call low dose, but then ultra low dose, or 0.5 milligram per kilogram. And the somewhat unexpected but delightful finding was that both doses of low or ultra low dose ATG provided for significant preservation of C-peptide relative to placebo in new onset stage 3 patients. And similarly, you can see the A1Cs were lower in both arms, although only the 0.5 milligram per kilogram replicated the statistical significance in a lowering of A1C. There's just a tiny bit of overlap in the confidence intervals for the higher dose, and we can talk about why that might be in our open session. And the reasons for wanting to go even lower with anti-thymocyte globulin are certainly around convenience and safety. One of the biggest challenges with anti-thymocyte globulin, because it is a rabbit product, is that it induces serum sickness in a large percentage of patients who receive it at certainly higher doses. So you can see here in this 3 columns, you've got the placebo patients in the first column, no serious events, no CRS. But even at 0.5 milligram per kilogram, so 24% of patients had CRS and only 32% had serum sickness, as opposed to in the final column, when you go to the low dose 2.5 milligram per kilogram, now you're getting up to where 80% of the patients had serum sickness and 30% or more had CRS. And so if you could provide a drug with a single day that had similar clinical outcome benefits and had a lower side effect profile, certainly that would be intriguing as an opportunity to study down the road. So the MELD study has added to our cadre of therapies by way of confirming for now a third time that low-dose ATG can preserve C-peptide and may have other alternative uses. Another study that's been very interesting to everybody is the BANDIT trial. This was a study of baricitinib, a JAK inhibitor that was explored in also new onset stage 3 patients. This is a different therapy in that this one is given as a pill, an oral dose once a day. And here we see the data from that trial in which C-peptide, again, was significantly preserved in the patients who got baricitinib compared to those who received placebo. Unfortunately, they were unable to demonstrate a significant reduction at a year in insulin dose or A1C, but you can appreciate the trends there with the treated patients in blue. And again, in terms of safety and efficacy, always a trade-off. As Colin was saying before, that risk-benefit discussion is really where we're getting to now that we have therapies that have demonstrated ability to interdict the disease. Which one is best for any particular patient may largely be dependent on individual families or patients' level of comfort with that risk-benefit. And here you can see the rates of AEs in the placebo and the treated group. But most importantly, they really were very low in terms of overall serious events. In fact, there were more serious events in the placebo group.
So I think, we've heard about 3 different therapies here. Mike, maybe you can tell us a little bit about serum sickness, because people might worry about that, and you have more experience than probably anyone else in the world. And I was emphasizing the fact that these are one-and-done therapies, what baricitinib isn't. But how do you talk about that to your patients? How do you see serum sickness?
Yeah, a large part of deciding whether to offer a disease-modifying therapy to a patient is, in my opinion, making sure they have a real understanding of what they're getting into. People need to understand just what the risks and likelihood of those risks are. Most of the families who have come to us for either these clinical trials or even considering use of teplizumab on-label or low-dose thymoglobulin off-label want to understand what that looks like. And so, I show them the data, and we talk about cytokine release being what it is. Nausea, headache, sometimes low-grade fever, can even progress to having involuntary muscle contractions, tremors, that requires drugs like Toradol and Demerol to relieve them. They're short-term, but they're significant, and so it's important people understand that. And then the biggest challenge with the rabbit thymoglobulin is, of course, the serum sickness. This occurs because the rabbit antibodies are recognized by the human immune system after they've done their job of binding to the lymphocytes and are needing to be cleared. And when that process happens and they precipitate out, it causes 2 to 3 days of usually a rash and then some significant joint swelling, joint pain. That is very uncomfortable. And as you can see, that occurred in almost 80% of the patients at 2.5 milligram per kilogram dose. In the MELD trial, and similar to what we saw in the TrialNet study, but was significantly less, down in the 30% range when you just gave the 0.5 milligram per kilogram dose. But nevertheless, that's a huge downside to rabbit antithymocyte globulin, and another reason we need additional disease-modifying therapies. One of which that's being explored now is a fully human antithymocyte globulin. That's in a trial called the Safeguard study. That's now open to enrollment, and so that drug, because it's a fully human polyclonal mix of antibodies, does not cause serum sickness and gives another opportunity to move forward with disease-modifying therapies that might be even safer for our patients.
Yeah, that's very helpful. Olga.
May I add something to that? I think the most important issue is that the people, the families, get the opportunity to get information. And written information about is not only the action but also the adverse side effects, and then give you them the possibility to discuss it and go through. And then the questions are, okay, they want to know, the parents, because talk to the parents also for the young people, young adolescents or young adults I'm dealing with. They want to say, okay, and if that happens, what can we do? And obviously we have a good experience, and we say, and we will show you how to prepare the infusion and how to reduce all these side effects as well. And the other question is they put to us is, okay, what are the long-term effects beside the preservation of beta cells? So this is also very good to have information of the long-term safety data, and also to have understood how is the pharmacokinetics and pharmacodynamics. So to say this is immunomodulatory in treatment, as you said, happens once or twice over a certain period of time, and then after that the agent is not here, so we wait to see how it is the efficacy of the autoimmune process we are dealing with.
Yeah, and I think it's really important points. And a lot of people, they may have heard of ATG, for example, as used for transplantation, but we're talking about 15 milligrams per kilogram there, not 0.5 milligrams per kilogram. So it's important to separate those sort of things in your head. And although people do get serum sickness, everyone recovers from serum sickness, right? And it's not something that goes on for the rest of their life.
Yeah, excellent point, Colin. It's a self-limited side effect, and as long as I've been doing this, I feel like having had the experience and talking people what to expect and having realistic expectations for it, families usually come out on the other end saying that wasn't as bad as I thought it might have been. And I'd rather, frankly, oversell the side effect profile than undersell it and somebody have an unexpected side effect that they weren't ready for. But yeah, it's 2 to 3 days, it's self-limited, it goes away. And when you can point to long-term benefits, looking at objectively data now from multiple trials showing C-peptide preservation and even A1C lowering, families have to think long and hard about whether or not that's something they're ready to do. And like Olga was saying, I think every one of these patients deserves and requires, several conversations to make sure they're really making a fully informed decision, whether it be a clinical trial or use of on-label teplizumab or any other therapy.
We do have a couple of questions now. So I've got ATG. So what is the sweet spot dose? 1 milligram, regardless that they didn't test that dose. I don't know what they say that's between 0.5 and 1, and they didn't test that?
So they did. I didn't want to go through all the data for you, but so there were 5 arms. There was 0.1 milligram per kilogram, which is probably homeopathic. There was the 0.5 milligram per kilogram. There was a 1.5 milligram per kilogram arm, and then the 2.5 milligram per arm and placebo. The design of the study was this adaptive trial design so that the lowest dose arm that still met the early immunologic signal was going to be the enriched arm. The 2.5 milligram per kilogram arm was always going to be kept, and a placebo arm was always going to be kept. So it turned out both 0.5 and 1.5 did reach that threshold, but the 1.5 milligram per kilogram arm got dropped because the trial was designed to test the lowest dose that reached that threshold. That being said, there were a small number of patients in the trial who did get 1.5 milligrams per kilogram, and while I think it can be dangerous to look at that data with too much intensity because it's not well powered, they did extremely well and had very nice preservation of C-peptide. So there may in fact be something in the middle that works even better, but I think the key finding, the key takeaway is there is a range of therapies, doses with low-dose anti-thymocyclobulin that have now repeatedly shown benefit and confirmed the observation.
And it's certainly less than the renal dose, right?
And yes, every parent who comes, that's the first thing they read, is this chemotherapy, is this a transplant dose? And, describing the difference between side effect profile and a 0.5 milligram or 2.5 milligram per kilo versus 15 usually allays most people's fears. But understandably, that's the first thing that they typically see.
Okay, take one more question and I'll take your question. So this is, I think, for you, Olga, but it says, apart from delaying the onset of stage 3 type 1 diabetes by teplizumab, any benefit in lessening the severity or the progression of type 1 diabetes? I don't know how you want to interpret that, but...
We have data from the PROTECT study, which is the teplizumab study, a little bit different design because it was given twice, within 6 weeks after the stage 3, after the beginning of insulin treatment in stage 3, and then 6 months later. And we have seen in that study that it helps to preserve the beta cell function over the 52 months, if I remember well. So what we can say out of that is that even those they go to stage 3 after the teplizumab treatment, we could expect that they have a better endogenous beta cell preservation. And we have also the first results from the US showing that the experience with the teplizumab treatment in 30 patients in the US since November 2022, and those 4 out of 30, they got type 1, stage 3 type 1 diabetes. They had very low insulin needs for the time of the follow-up. I think it was below 2.3 units per kilogram. So this is something supports this idea that even if you get reach, say, 3 after the teplizumab treatment, you may profit out of that.
And I think even with 80 months of follow-up from it, there's still about 36% of the people who haven't developed type 1 diabetes yet. Whether anyone will never get it, we'll just have to wait and see whether that happens. Do you want to just come up to the microphone? Thank you. And just introduce yourself.
The discussion about teplizumab is going on also in Cyprus, and many colleagues are having this question. What would be the benefit of trying to delay diabetes type 1 with the risk on the immune system if not completely treating the disease of diabetes 1? That could be my question.
So I think your question is, we've got an immune risk, as you're saying, and how does that play out versus the disease doesn't go altogether?
The benefit of,
So I'll probably pick that one up, because in a way it plays to what I was trying to discuss at the beginning, that 2 to 3 years without insulin is a huge benefit, more than people realize. I mean, probably like you, if I say to one of my patients, would you like a day without insulin? They go, yes, please. Would you like a week? Yes, please. Would you like 2.5 years? Of course. You don't feel it in quite the same way when it's at the beginning, but otherwise those children would be on insulin during that prolonged period of time. And they've also got those benefits, the lifestyle benefits for those 2.5 years, but that potential long-term benefit. We won't see that for many years, but as we transform the disease into one that is diagnosed later, and as Olga says, where you have persistent lower levels of beta cell function that persist, we'll probably see less hypoglycemia, better glycemic control going forward. So we wait to see, but there should be some long-term benefits from that.
May I add with the voice of a patient, because she came to us to get the treatment, and the reason when we discussed about why to do and how what has to expect it, and the reason she said to us, you know what, I'm going to do that. Of course, she was very well known about the type 1 diabetes in her family because her sister was treated for type 1 diabetes. My goal is to do my final exams in the school without insulin treatment. This was the mid-time goal. And she has reached the goal, and she is over 12 months without type 1 diabetes after the treatment. So going the conversation with the people, you know, this is what is also important for them. But we have to discuss with them based on the data we have from the studies.
Yeah. So now we're going to be a bit more practical because these therapies are not in our normal playbook. We're not used to this kind of thing. It's different workflows. It's different ways of having team members. We need to think about things differently. I mean, it's incredible the team you need for insulin, right? It's not like a tablet prescription, but we'll need a team in a different kind of way, and particularly for infusions. So many of the things we've talked about, maybe not the baricitinib, but many of the treatments are infusions. Thank you. And so we're going to talk a little bit about what are the practical differences in giving this kind of therapy. Olga.
Yeah, I'm going to start with the issue on dosing and administration of immunomodulatory infusions. Here you see the list of agents they are given intravenously, and this is also the teplizumab belongs to this study. I'm going to focus to the teplizumab as it is approved for the treatment of stage 2. And here you will see that we have a 14 days course, escalating the dose, which is calculated based on the body surface area over 4 days, and we reach the final dose on day 5, and continue with this dose until the end. There are some information I can give to you that it is the agent is administered intravenously over at least 30 minutes. We do it over 60 minutes and then go down to 45 minutes. It is very well tolerated. So the minimum are 30 minutes. However, we start. I don't know how you do that with 60. The infusion has to be completed within 4 hours of the start of the preparation. Now in Germany go up to 6 hours, and 2 doses are not be administered in the same day. What I have told you that it is very useful to do is going to be shown by Michael.
Michael, say a little bit about the pre-medication. So we said there are potential side effects, but a lot of them can be prevented. Mike.
Yeah, so when we're talking about pre-medicating for teplizumab, certainly the recommendations are to give antihistamines and paracetamol, acetaminophen, or non-steroidal anti-inflammatories. And those drugs really are helpful to mitigate some of those infusion reactions. When we're talking about using other therapies like anti-thymocyte globulin or rituximab, sometimes we have to give steroids along with those, which of course are important to talk about with the families, because oftentimes they'll have higher blood glucoses the days of these infusions or even the couple days after they're done. So again, it's really important to give them that expectation up front so they're not caught off guard when their numbers are running higher. Especially in today's world where we're treating a lot more patients with later stage 2 diabetes with teplizumab. We certainly have some who see blood glucoses above thresholds for stage 3 during the infusion, and it's important to make sure that they're aware of that. Monitoring is just standard, so make sure that you can access vital signs and having those done regularly throughout the infusion, so you're not missing somebody who's having a fever or having hypertension or tachycardia. Being ready for cytokine release syndrome is really important, making sure your nursing staff knows what to do in case that happens. Generally, we see a fair number of folks having infusion reaction, some nausea, some headache. Not all, in fact, very few reach the formal definition of cytokine release syndrome, which requires fever. But even just pausing or slowing down the infusion is usually enough. If more than that is needed, sometimes a dose of an IV nonsteroidal like ketorolac is really helpful for those patients. And then follow-up, of course, requires appropriate post-infusion monitoring to make sure that they're stable before you send them home. And so the medication before you give teplizumab is really key on those first 5 days. Generally, in our hands, we give that 30 minutes before the infusion is to start. And we do that for at least the first 5 days with the option to continue it as necessary. I must say that most of our patients are very happy to stop taking the pre-meds once they're past those 5 days because the antihistamines, especially when we're using sedating ones in my clinic, tend to make those patients very sleepy for the rest of the day. And they're happy to be done with it, and they're also happy to have their infusion time be even more short by way of getting through that. So once you've gotten through those first 5 days, we've been very successful with not having to give them thereafter, but you're also always going to have them available to you. All right, and then in terms of monitoring during infusions, again, we want to have vital signs measured regularly. We have a standard protocol for every 15 minutes, and then ideally for a couple hours afterwards as needed if there's an infusion reaction. You want to monitor, obviously, during and afterwards for any of the things that you see listed there and be ready to manage them if necessary. Fortunately, in my experience, I've only had to deal with a couple folks having low-grade fever. Chills, headache, and nausea are fairly common. Thank God, never have seen anaphylaxis, never have seen anybody have wheezing, urticaria, or hypotension from any of the drugs we've talked about today. And then, of course, if those things do happen, you would extend the observation period to make sure the patient's staying in your clinic until they're really fully stable and able to go home. The emergency plan for cytokine release syndrome, so you got to have these things available, always be prepared, and hopefully you'll never have to use them. But certainly we have a crash cart in our infusion clinic with epi there that we could give intramuscularly or IV if necessary. High-dose steroids or any other, dexamethasone is what we've listed here, but any steroid would work fine. Additional antihistamines, of course, which you'll have on board and ready to give that you've already used for pre-medication. And then resuscitation equipment if, heaven forbid, something should really happen that's significant. But again, I've never seen that with any of the drugs we've mentioned, knock on wood, today. And then I think the next comment we're going to talk about is how to deal with IV access and the considerations there. And I'm going to hand it back over to Olga.
Yeah, I think I would like to tell you something. Michael, a colleague told me the day yesterday. Actually, we are endocrinologists. We now have to know to work like rheumatologists, gastroenterologists, or allergologists.
I thought we were physicians.
Yeah, I mean, as a pediatrician, we're used to do that, and it helped us a lot to set up our internal protocol, how to monitor and how to provide it, and even to find the good solution about what kind of intravenous access we would like to use. In children, actually, we work also with peripheral IV lines. We don't have to establish PIC, but of course, if we have to do with younger ages or some situations, we have to think about that. And we have learned that the kids can go home with the IV peripheral lines. This is something we use also in other situations. But of course, this has to be adapted to the local situation and how it is. We discussed, we had a case with a child, 8-year-old child, who was really suffering by putting a new IV, and then at the end, or the last stage, we have discussed with our anesthesiologist, and we prepared her, to be in good condition to get a IV line. There is a small child like that, so we have to work accordingly. But actually, it is not the most difficult issue. But this is something we have to talk about, I think is the next issue.
I'll just add, I've done teplizumab infusions both with peripheral IVs and with peripherally inserted central catheters or PICC lines, and I agree, it's really a patient preference. Although having it done both ways, I strongly encourage putting in a PICC line because it just makes it so much easier to get labs and to not have to poke, especially pediatric patients, repeatedly. But there have been families who just don't want to go home with anything in them, and so who have gotten IVs placed every day for infusion. Some others who even kept an IV for a few days and used it that way before it gets replaced. So those are all options that are on the table.
Okay, so people worry about vaccine requirements. What are the vaccine requirements? Although there's lots of ticks and boxes here, I don't think this is evidence-based, right? This is just people, with some of the drugs, rituximab, that's been used more widely, but it's been used at doses for malignancies, as opposed to the dose we would be considering here, which is a single dose. And ATG, of course, has been used at levels for transplantation, not at these very low doses. But here's what it sort of says on where there is a label anyway, and there's only one that has a label for type 1 diabetes. But you can see that all of them say keep up to date, so that's the first column over there. And then it's really only with rituximab and teplizumab that they have an issue with the non-live vaccines. With all the others, the live vaccines you want to keep away for a period beforehand and during the treatment, but they can be introduced later on. So in the end, you can catch up with your vaccines if you're not fully up to speed. Okay, so now we're going to talk a little bit about the infrastructure requirements. What about people coming a long way, not a long way? How does all that play out?
Yeah, so having now done almost a dozen teplizumab infusions on label, along with probably 30 or more done in the research setting, our team has had a good amount of experience to figure out all the logistics, but they are not trivial. And so I think one of the big challenges for these disease-modifying therapies is figuring out how to make that work in your system, and that's going to be different for every patient and every family and every hospital system or clinic. Certainly, it's key to have an infusion clinic staff that are comfortable giving immunotherapies. So as Colin suggested, we've now kind of transitioned from being diabetologists to immunotherapists, and working with those teams who have experience there has been really, really helpful to get those things set up and make sure that they're all comfortable doing it. The irony is since we moved from doing this as a research entity into our clinical space, often our clinical nurses who are used to giving chemotherapies for much worse diseases are quite comfortable with giving teplizumab. On the other hand, if you go do this in a place where somebody has never given these therapies, they can be very anxious, and that is something that parents and families pick up on very quickly. So really making sure you have a team that is comfortable and knows what they're doing, I think makes for an importantly good situation, good experience for your families. But this is certainly with teplizumab, it's a drug that requires 2 weeks of people's time. And so in the US, we have patients often traveling from quite a far distance to come to centers of excellence that know what they're doing. And so making sure that you've thought through how they're going to get to you, where they're going to stay, is there support for their lodging, is there support for gas and food, those kinds of things can be really important for either low SES families or families coming from a distance or rural. The makers of teplizumab do have options for that when patients qualify. So it's important to make sure that we think of that and make sure that we're not only providing this drug to folks who are in the upper classes and can afford to take 2 weeks off of work. Obviously, not everybody can do that easily. And then, of course, you have to be able to give all 14 days consecutively without interruption. And so I imagine there's going to be quite a big difference in how that works in the United States versus the European countries, and maybe even from country to country. And so, like I said at the beginning, I think that's going to be something that every place is going to have to work out for themselves, but certainly important to think it through ahead of time.
Yeah, and obviously, in Europe, it's new for us here. We're working out different ways of doing these kind of things. But just to say a bit about the team that you're going to need to have. So you do need trained infusion nurses with competency in managing the immune-related reactions, but they can learn to do these things. We generally need an on-call clinician oversight for lab review and adverse event decisions. I don't think you get many calls, but you do need to look at the labs in the first sort of 5 days. Clearly, pharmacy coordination for timely drug administration so people can get in and out quickly. And the team readiness for monitoring, documentation, and follow-up of care. And of course, we need those clear protocols for after-hours patient support should it be needed. Is an intensive care unit required for teplizumab administration, outpatient or inpatient administration?
No.
Okay.
No, yeah, certainly you don't need an ICU available. I think those first few days, it's, in my opinion, the infusions really need to be done in an infusion center where you have people with expertise to take care of an adverse event. There are people who have done the full course of teplizumab at home. I personally don't think that's the best way to do that because I think it sets us up for challenges when somebody does have an infusion-related reaction. Once you're past that first 5 days, though, for many of my patients and families, it's far more convenient to do it at home. And so I've often used a combined home health care agency with infusion clinic model. But yeah, you don't need to do it in an ICU.
Did you want to?
Yeah, I have heard from a French colleague yesterday that they also do this hybrid structure, that they have the first 5 days or half of days in inpatient, and then they have home expert teams that are going home, and because they use it also for oncological treatment.
Great. And then it says here, the question here, given the transient T-cell modulation, do you recommend systematic screening for latent TB or only in patients with epidemiological risk factors? So we do recommend that they have screening for hepatitis, for HIV, and for TB in advance, and EGRA test, I think, is what people do standardly, yeah.
Yeah, and importantly, Epstein-Barr virus and CMV as well. So you definitely don't want to have a primary EBV infection when you're getting certainly either thymoglobulin or teplizumab. And so making sure that if they're seropositive, that they're asymptomatic and ideally PCR negative for those around the time of treatment is really important.
May I add something to that? Because sometimes it takes time from your basic evaluation regarding the inclusion criteria until you get all the bureaucracy, the approval to provide the treatment. So we have learned if it is more than 3 weeks between that, we repeat the EBV serology at latest at the first day of the treatment. If we have no clinical, of course, if we have clinical signs, we have to discuss earlier about that, but we have a second evaluation, EBV, CMV status at the first day of the treatment.
In clinical trials with teplizumab with a second cycle, which is what was happening in the PROTECT study, is tolerance expected to be better than in the first administration? So does it make any difference the second time around? I don't think so, but anybody want to comment on that?
That wasn't our experience. So we were a site for PROTECT. Patients did well with both infusions, frankly. There is an issue with teplizumab developing blocking antibodies, so you may actually have less effective drug around. I'm not sure if that therefore means there's less likelihood of a side effect profile. So if anything, it was maybe a little bit less than our experience, but that's a little extrapolating.
And the related question is, does it make any difference whether it's given at stage 2 or stage 3 in terms of side effects?
No.
Not seeing that.
It's acting on the immune system.
I mean, it is better. It's getting better the second time. You have less.
Okay.
This is published. I think this is published.
Okay, let's move on now, because a lot of these questions relate to the education, preparation, communication. What are we going to say? And particularly thinking about that patient experience and focusing on the patient experience. So I'm going to pass over to you. This is yours, Mike.
Yeah. So we thought it'd be helpful to go through some real-world data now that teplizumab has been out there. So this is published from some survey data Dr. Kelly O'Donnell put out there. And what she looked at here was the folks who had gotten teplizumab. And so here you can see the breakdown of the demographics. So half of them had a family history of type 1, not all of them. So that's the real experience in people getting the drug, even though TN10 was clearly in patients who had a first-degree relative with type 1. There was a large number of folks who were actually mislabeled as type 2 initially. amongst the adults who got into teplizumab. Again, we know that happens all the time in our adult colleagues, and those of us who do type 1, we get phone calls about those patients regularly, and that's a big population of folks for whom this could be a therapy that's an option for them, but only if they can get correctly diagnosed. And then, a third of them, not unexpectedly, had other autoimmune diseases. And when they asked them, what was the reason that you would screen for and take teplizumab, 3/4 of people said that more time before needing to use insulin was important to them, either very important or important reason for screening. And 98% said that the rationale for treatment, was to delay their disease. So people, it seems like in the real world, understand why they want to do this, and they were grateful for the opportunity. But it's important to recognize that the population that's been treated is somewhat different than those who were in our initial clinical trials. So Holly also looked at folks who were caregivers of a child with type 1 and asked them about their level of anxiety or worry. And would their child tolerate the drug, and compared that to adult respondents. So you can see there, the duration of time since they were treated. So these were all folks who were answering basically within the first few months to a year of their treatment in the adult world, and similarly on the caregivers on the right side. And you can see the folks who said they were very worried was almost 1/4 of adults and 1/3 of caregivers. And a little worried was 3/4 of the adults, and again, almost the remainder of the caregivers. Very few people said they didn't have any concern at all. And it's really important, and we make sure that we do give people the appropriate hand-holding that they require to go through this. It is a different paradigm when we're talking about using immune therapy in type 1 diabetes, and it's exciting that we are here now, but it does require conversations with those folks and acknowledgement that there is a good bit of anxiety about, will they tolerate it, will they benefit from it, what will the long-term effects be. And so Holly also did some questions related to how did people feel after the fact. And this is what they said about their experiences. 87% were grateful to have received teplizumab. That's a pretty good track record for an immune therapy, I would say. 81% would recommend other people getting it. But still, 62% of these patients who were stage 2 were checking blood sugar often and still thinking about their disease. So it's important to recognize we're not completely taking away that burden. As Colin said, it is a huge deal to not need insulin, and there's definite clinical benefit to that in both the short and long term. But that feature right there, that figure, tells you that these patients, understandably, are still worrying about their disease. And so much so that 68% of them are still worrying about what to eat on a regular basis. And I must say, in my practice in treating these patients, people will work extremely hard to not take insulin if they think they have the ability to do so. And people do that by all kinds of means, some of which may even be unhealthy. And so we spend a lot of time talking to that about families. The transition to potentially needing insulin is not necessarily a failure. It's just the disease is hard to treat, and that they may still be getting a lot of benefit from these immunotherapies, even if they do need to use some insulin so they can eat real food. And then she also asked them about their outlook on the future following the treatment with teplizumab. And 72% of the patients thought that the drug helped them slow down when they would get type 1. So again, people felt like they got benefit. 60% thought teplizumab would make their disease easier to manage when they did progress to stage 3. So again, a really important point that we need to prepare people for. The response to this drug is heterogeneous. We know the reality is even if they get a huge benefit and delay, most patients are going to present or progress to stage 3. But explaining to them that they may still benefit from it is important, and most of the patients did appreciate that. And ultimately, almost 90% said they would make the same decision about teplizumab for them or another family member.
And if you go to the European side, we have a nice paper by Bombacci from Italy, who has asked caregivers of parents of children at risk to develop type 1 diabetes, and they got similar information. It was really surprising to see that only 6.3% were aware about this kind of modern treatment But half of them were ready to consent to teplizumab treatment. And interesting is that those they have already experienced DKA in one of their other children, they are more significantly more ready to consent a treatment with teplizumab. So I think this also having experience, very close experience, what does it mean living with type 1 diabetes and its complications, give a big push for undergoing something, a new treatment. And we have some experience also from the UK.
So in the UK, the ELSA team surveyed patients who had been for screening. They weren't given teplizumab because it's not available at that time, but they asked things like, is a 2-year delay meaningful to you? And responses they kind of got was possibility of treatment brings hope, perceived effectiveness, some really understood the benefits of that 2-year delay, and that there was a minimal treatment burden beyond the initial treatment. There was a frustration around not having the treatment available and extreme lengths to gain access, for example, to teplizumab. Hopefully, before long, that won't be so much of an issue, but it is a frustration if you know that something is available. And then what about the children's view? It's not, the teplizumab license outside of the UK is not just in children, it's about anyone above the age of 8 years old, but it does include children. And what's their view? And this idea that it should not be about them or without them, it should involve them in their views. They need to be involved in that decision making and understand what they're going to go through in a way that Mike described. They need to understand in their terms what this experience is going to be. And there's always the issue about whether it's too invasive for young children with additional needs. You know, there's other complexities going on if they have other comorbidities. And then finally, enabling factors and issues that Mike touched on a little bit. He talked about the distances, but often there's other factors as well. The time that you need to have off school. I think pretty much during those infusion periods you won't be able to do school. Some people do some schoolwork while they're sitting around having the infusions, though. Reasonable adjustments to work and financial burden, that's for the parents alongside the children as well. They're going to have to take time off to support them during that period. And the care responsibility for the other children. While you're looking after one child, you have another child or more than one children. So these are all things that people do worry about and need to be taken into account. Okay, well, we've got time now for a discussion, and we've got lots of questions that have come in for you. We've put a few topics up here that I don't think you need any help because you're coming out with lots of questions here. But anyway, things that we might discuss: educating and preparing patients and families for teplizumab therapy, for example, strategies for working with patients to ensure the scheduling works, and alternative management strategies when teplizumab may not be suitable, for example, clinical trials, alternative therapies, other support that you'll be able to offer individuals. So I think what I'll do, let me just pick up a few questions, actually, if that's okay, and then feel free to add more in on these topics, or to come to the microphone if you want to. So what comments can the expert make about checking for reactivation of latent viral conditions? So, Mike, you referred to you didn't want acute viral infection. You don't want to treat somebody while they have active EBV. But what about reactivation, for example, of EBV?
Yeah, so reactivation of viruses is certainly a known risk factor with any immune modulation, even short-term immune suppression. So we've definitely seen a few cases of reactivated EBV following teplizumab and anti-thymocyte globulin. Generally, we just have to treat those patients symptomatically, make sure we provide them with support for those issues until they get better. People have certainly, in study situations, gotten serial serum values to find viral reactivation even when patients didn't have any clinical symptoms. So I think you can see that not uncommonly. But if it's completely asymptomatic, it's not really clinical, it doesn't make a big difference for most of these patients. I think the biggest key for me is making sure we don't give somebody one of these immune modulators during that a primary viral infection. So as Olga mentioned, a PCR close to infusion, certainly if there's been any recent history of symptoms, is really important to mitigate that risk.
And there is no urgency. It doesn't have to be today, right? You don't have to give the infusion today. You prepare the patient appropriately.
Absolutely.
Do you want to add anything to that, Olga?
No, I think this is what I have learned about working with the plizumab treatment is that communication, a very open communication with the parents and with the patient is very essential, because most of the side effects you have, that is laboratory effects. The patients are doing well. Some of them, they may have some headache on the first day, or be a bit, as you say, sleepy because of the pre-medication as well. But it is very well tolerated, and it is nothing special. And we have never, up to now, have never experienced an infusion reaction during the infusion. It's well tolerated. This 1 hour, we have to work with them, and then after the 2 hours of the monitoring. But, and what we talk to them is we have no signs, but we're doing this because it's a safety procedure, and if we find something we have not expected, we discuss with you and then discuss how to proceed with. This is all the preparation we need. And the other issue I have learned is that in some cases I had a reactivation of ABV. It was after the treatment, not during, but after the treatment, mostly 1 to 2 weeks after the treatment. And then because they are not in our, some cases they are not in our supervision, they go to the family doctor and say, please, if you have some symptoms like the EBV, please talk to them and lead them some laboratory exams in order to be aware whether it's really ABV reactivation or not, and then take contact with us. So contact us to discuss with it. But it is self-limited, as you said, particularly if the persons are immunologically healthy, they have no other conditions.
Yeah, I mean, they often get lymph node increases in size of their lymph nodes and the sore throat, and it's important that they contact you to be aware of that. On occasion, people have needed steroids at that point in time, but it's always going to resolve because their immune system is recovering during this period of time. It's that dip where the EBV can reactivate, and then the reconstitution. The two come together, as Olga says, about a week or two after the infusions are finished. It's very characteristic. Okay. So there's a couple of questions about combinations here. So one says, do you anticipate helping patients decide which DMT to pursue or whether a combination is best? Will there be future work on combinations? And has there been studies where a second drug is used, such as the GLP-1 separately or co-administered? I'm going to pick that up because I like combinations. So combinations are always tricky in terms of medical studies because you need to know if there's a side effect, which drug it is. But it makes an awful lot of sense to use combination therapies. On the other hand, as I said about the blessing and the curse of insulin, we are in a situation unlike multiple sclerosis where we do have another option. So we cannot risk significant immune compromise. And that's what we've been talking really about most of today, that we've been very careful to try and get it into a band, if you like, where the risk is small. Once you start putting two immune agents together that maybe hit the immune system at different levels, we have to be a little bit careful now about what that combined effect would be. But people have been interested, for example, we haven't talked about other drugs that may be not operating through the immune system, working through the beta cell. So that suggestion of whether GLP-1s would be helpful, there has been one study which combined GLP-1 with an anti-IL-21. And again, they were struggling a little bit to figure out which ones they needed, whether they really needed the two together, and what is the GLP-1 doing in that mix. So watch this space. I think there's going to be a lot more in this in that context. And I guess the other question is sequential therapy. So if one drug wears off, what about introducing something else at a later stage? So I think there will be conversations. At the moment, it's not a very complicated conversation because there's a limited number of drugs available. But somebody then asked the question about clinical trials. Which clinical trials do you consider for your patients? maybe I'll ask my colleagues about that.
I would like to answer your question in the context of having teplizumab treatment before that. This is something we have to discuss really, because if teplizumab becomes available in the routine care like we have in Germany, of course we say that the parents and the patient, you may gain 2 years or 3 years or even more, and then you have time to try something else that may help you, another immunointervention. And at the moment we have the problem that all the new trials, they are scheduled, they have as an exclusion criteria to be treated with teplizumab or another issue. So this is something we have to discuss in the scientific world, how to cope with this issue as well. Other sides, we have, in Germany, we have some running trials with stage 2, which is the baricitinib, have started, I think in the US as well. And this could be an option for those they don't want to have a treatment with teplizumab.
Well, just before Mike chimes in, I've got another question which you can add into this. It says, there are many therapies being tested in clinical trials in stage 2 and stage 3. What are you excited about? And how should physicians who are at centers that do conduct clinical trials share information about research opportunities with their patients? So, what are you
thanks
excited
for that
about,
question.
Mike?
I'm excited about the whole space. I think we're really at this paradigm shift where we're going to convert the disease from something we can only treat with insulin and glucose monitoring, which is, like you said, is a blessing, and it's gotten so much better, to actually treating the disease itself, and hopefully we can do so before people need insulin. TrialNet is in the process now of rolling out studies in all stages of disease. So we're planning stage 0, stage 1, stage 2, and stage 3 studies, and hopefully we'll even have some studies for folks who have long-standing disease down the road. Not all of those are open yet, but we do have some that are, and some that are close to being open. So, for example, in the stage 2 space, we're about to open finally our study of comparing active therapy teplizumab to rabbit thymoglobulin. An important question, because we need to see if other disease-modifying therapies might work in the stage 2 space. But we learned the hard way that families, once there's an active therapy available to them, are not going to participate in placebo-controlled trials in that space. We tried it, and it did not work. And so I'm excited about the opportunity to also move the field forward in considering different trial designs. So using active therapy comparators, using other metabolic or immunologic markers to get early signals, because we can't afford, in terms of time, to take 10 years to find the next therapy. We've got to get faster, we've got to get more efficient. So there's lots of them coming. The human ATG is available right now in studies in stage 3. Frexalimab is a really exciting target with CD40 ligand that's filled the first two portions of that study. TrialNet has filled fully a study of a combination therapy, rituximab and abatacept, so we'll have data from that coming within the year. And then the JAK inhibitors, in addition to baricitinib, TrialNet has done a study in new onsets with ritlecitinib and abrocitinib, two sister agents. So hopefully we'll have additional information to share about the JAK inhibitor space. And bring all that together, it's exciting. I think we have a growing pot of tools to use to consider combination therapies and sequential therapies that can really interdict the disease meaningfully.
But I just wanted to switch tack maybe a little bit to say, beyond physicians and nurses, what other professionals are typically involved? For example, psychologists or dietitians. How frequently these individuals reviewed? And just linked to that, with increasing identification of pre-symptomatic individuals, how are centers organizing the follow-up of these individuals? So I'm just going to put those two questions together a little bit and say, what about other professions, not just necessarily medical professionals? How do you see that multidisciplinary team dealing with patients at these different stages and in the therapies?
Yeah, great question. So I think the professionals that are not used nearly enough are the mental health professionals. That's true for all stages of disease. But there's a ton of anxiety, at least in the patients that I treat who are in early stage disease, regardless of whether or not they choose to ultimately to go with teplizumab or wait. And I think we do them a disservice by not getting the mental health folks involved as early as possible. A lot of what we end up doing in our early stage clinics is frankly counseling and mental health anyway. So we really need to be using those experts who know how to give behavioral therapies for that and not just relying on the physicians or the nurses.
So I'm taking the questions on the other point, saying all the people they have gotten the teplizumab treatment, they stay at a stage 2. Mm-hmm. So we recommend glycemic monitoring according to those for stage 2. That means every 3 months hemoglobin 1C and OGTT every 6 to 12 months, if it's possible, with C-peptide measurement. And for that reason, we use sometimes the time of the 14 days time just to educate them in case there are some lack in knowledge how to perform blood glucose measurement, because we ask them to do it once a month at home or to ask to provide some education. It is important to say that healthy dietary habits are very, very important to avoid restriction habits, to have a very healthy and sportive, activities. This is something we try to combine for the time they are with us during the treatment.
Okay, I'm going to deal with 2 more, but again, great questions. Maybe you can come up to us afterwards. One, which I think is a quick question. Where do we stand with moving the age indication for teplizumab in children younger than 8 years?
So the PETITE study, which was the study of teplizumab in children 1 to 8, was recently published for their initial analysis. It was a planned but early analysis with very encouraging data of no new safety signals in the large majority of those children not progressing to stage 3 in a year, and these were quite young kids, so high risk for that. That packet of information is being considered by the FDA currently, so the hope is that we will have a reduction of the age limit for being eligible for teplizumab, but that's not yet happened in the US.
This is a longer question for you, Olga, but you can squeeze it in, but it's a very important one, of course. How do you identify patients with stage 2 diabetes?
It is a very exciting issue. I think, really, to be honest, this is new experience. Of course, if you follow up the children through a screening program, when you have the stage 1, and then they're going to stage 2, it may be a little bit easier. But most of the referrals we have, they are from colleagues because they have measured a slightly elevated hemoglobin 1C. For example, 5.9, and then you start doing the staging, and then you see a lot of combinations. What we're doing it is just to say, do we have the criteria as they were defined? If we saw we have multiple antibodies, that means 2 or more, at least twice confirmed, maybe from 2 different laboratories. This is the practical way we have to see whether the rule 222 is fulfilled. And then we are doing the fasting glucose and OGTT, which is sometimes a bit demanding, not only the young children, but also adults. They don't like it, to drink it. And then we follow up, we evaluate the results. And then we have sometimes some interesting combinations, like having dysglycemic hemoglobin 1C and fasting glucose, and then pathological 2-hour OGTT. And sometimes we have only one dysglycemic criteria. So it is very interesting. I think we are following the consensus. We have discussed about that, but in the everyday job, you have a lot of combinations. Some children are also obese, and then you have a high HOMA-IR index, which is also not a good prognostic criteria for the progression.
I knew it was a big topic, but it is an important topic as well for us to address. Okay, well, we've had a good discussion here. So we've summarized this really. Type 1 diabetes management is evolving with immunomodulatory therapies, not just insulin. These aim to modify the disease course beyond improving glycemic control. There were some issues about using it in stage 3, which we haven't been able to address, but preventing insulin is the very special goal, which you can't achieve with technology. Clinical experience with teplizumab is helping define how immunomodulatory therapy can be implemented safely and effectively, and I think future therapies will be simpler than teplizumab as well. And I just want to take this opportunity to thank my colleagues who've given their exceptional experience and expertise through the discussion today, and thank you all for attending. Thank you.
Thank you.
This has been an activity published by Peer Voice.